you have that phrase of, oh, this is what we've always done. And that phrase really irks me because that's the absolutely worst thing to say, because that's how it's always been done means that it's supposed to be changed. I'm Andrea. I am from the low country of South Carolina. The hospital I specifically work at serves a lot of military, not only patients, but also our nurses. So we do have a lot of turnover, which is hard to get a lot of not only seasoned nurses, but just nurses who you can keep and get that culture. So we have a lot of difficulty with people just having a passion for the unit and then having a passion for the patients. Like they just come in and feel like it's just a job, or they don't feel like they're going to be there long, so they don't want to sink any roots. And you have that mixed in with young nurses or nurses who are looking at retirement at the end of the tunnel and don't want to be involved in much. I think the struggles that we have on our unit is we don't have a lot of the new evidence, and we're trying really hard to get it there. Our education department's kind of swamped, and our quality team is pretty swamped, and I've gotten my feet wet trying to get in it. I'm involved in a couple of those projects as well. So trying to help them out with bringing like the A1 and ACOG, all the evidence-based stuff to bedside and saying, hey guys, this is standard. This is what we're supposed to be doing. It's not unattainable. Let's try it. So I think we're just having those awareness conversations right now and trying to bring it to our bedside. So that's a big struggle we're having. And it goes for all topics. I think just with any change, it's difficult. And then again, specifically on our unit, you have that phrase of, oh, this is what we've always done. And that phrase really irks me because that's the absolutely worst thing to say, because that's how it's always been done means that it's supposed to be changed. And things are always evolving. It's really uncomfortable to see change and to have change happen around you, and people just aren't willing to open up and accept something different to change their own personal practice because it makes them uncomfortable. Yeah, it's a difficult situation. So you have the spectrum of what the nurses are expected to do and what the patients want to be done, all the different expectations coming from different pathways, right? So when the nurses or the healthcare providers are just strictly thinking this is what the hospital is wanting or this is what our unit is wanting, and they forget about the patient, where the patient is what we need to be focused on entirely. Yes, what the hospital sets in place and the policies are supposed to be built on evidence and keeping the patient safe in general. But when we look past what the patients are wanting and go just, that's policy, you're missing the point. So just remembering what is truly important and keeping the patient involved in that conversation, which brings us to our topic of informed consent as well. Just be open and honest with all conversation. Say with the patients, like, hey, this is where we're coming from. I see where you're coming from. Let's have a conversation. And having those conversations early. Ideally, not in the heat of the moment. Early is best. So in a perfect world, that would start OB appointment 1. We have a heartbeat. You have confirmed pregnancy. This is what we're expecting. And no, we're not going to talk about episiotomies when you find out you're pregnant. However, I don't want to talk about episiotomies when we're ready to cut. So that, having the conversations early on about what may happen through the course of your obstetrical journey before decisions need to be made. And just keeping people informed. And again, I say the word spectrum, but you have patients who are well informed, too informed, and then who don't do any research. And then the opposite, you have healthcare providers who we're supposed to be very knowledgeable. And then you have people who know base knowledge who can get through, right? And then you have people who have a lot of knowledge, or take, for example, our MDs who have all of the knowledge, our nurses who practice at bedside, who see things evolve really close at bedside, who can see things happen, talk to the patients, anticipating what doctors may say, or people who are just starting. We have the spectrum of the healthcare providers providing too much information as well, having scare tactics, or withholding information. But that's not our place either. If we're seeing things develop, our patients need to be the first people to know. I see a lot of people upset,
Yeah.
especially after people have things experienced to them, and it could be very minute. It doesn't have to be the drastic things. It could be, oh, I didn't realize that you offered the vitamin K injections here, or you don't have the oral option here. That's been a really hot topic over the last month. And they get to the hospital, and it's right before baby meds are due. And they're up in arms, and I'm like, oh, this is not the time. I've been educating you the last 3 days on everything else, but this is not the time to be having this conversation. But it didn't come up. So in my practice, when we sign the consent for hepatitis B, I say, now, there are other medications that we give. Let me talk about you now, about those. And at least start that conversation then, if they don't know about it. Because a lot of people don't know about erythromycin and vitamin K. So people just feel blindsided, I think. And you can do the best you can to help inform them. Um, and some patients feel like it's received, but you can have 5 people tell them the exact same thing, and just one of them gets through. So, and I hate labeling people as refused or non-compliant. It's okay. How were they explained? How did that topic get explained to them? Were they truly informed about everything? Because then you come to them with rephrasing how a vaccine helps baby after birth. Oh, oh yeah, I do plan on breastfeeding, and I do want antibodies to protect my baby. I'll get a shot. But if you just say, hey, do you want a shot? I don't want a shot. But if you explain what the shot is for and how it can help them and help their baby, oh, then yes, that will benefit me. Just complete informed. Keep them informed. Informed is power. I have little spiels every time I admit patients. So after I've gotten all of my hospital things done and we're settled and I'm ready to say, okay, I'm done. Is there anything else I need? We're turning off the lights and letting you settle. I I found a new acronym that I really enjoy. It's called BRAIN, and it stands for what are the benefits, what are the risks, what are the alternatives, what do I personally want, and I stands for myself and my baby, and what happens if we do nothing. And I say that that goes for everything. So whether or not you want an IV during your labor, okay, that's a choice. Everything is a choice, but use your brain going through that. And then same thing with like medications, Pitocin after birth, epidural, whether or not you do a vaginal exam now or none at all the different things. And then the big serious talks, getting a C-section, having the episiotomy. Does my baby look okay? Let's look at all the different things. You know, do you need to have all these things? But just asking the questions and the nurse's role in that you know when those questions need to be asked, or you know when the doctor's reaching for a pair of scissors to do an episiotomy, or asking for a vacuum, you know what's coming next. Talking to the patient, like, hey, let's ask these leading questions together. And sometimes being the patient's voice and asking the questions that they don't know they need to be asking. Because they can bring in their birth plans, or bring a birth plan that they can ask questions about, because the birth plan's always that, oh, they have a birth plan. All right, they've signed their C-section, you know. At least there's like a warning sign when that happens for us on our unit. I don't know if that's a red flag or not, but at least it tells us that they've the patients have looked at what's important to them. And just look at the birth plan and say, yeah, we do this already. It's not that big a deal. Or if there's something like, okay, they're here for an induction and they say they don't want an IV, let's revisit that. Okay, this maybe they made this months ago. Let's just talk it through. Don't come up in arms. Don't be hostile. That's not our position. We're here to help them.